Okay. Okay, right. Good morning. Good morning, all. Good morning. Good morning. I think we'll make a start. Good, everybody's here on time, 10:30, so we'll be able to go home sharp as well. Okay, so welcome to the last of the three regional events jointly organized by the Scottish Government and the communication, the subgroup of the steering group, mainly Health Scotland colleagues. It's Gareth Brown supposed to be chairing this event, but Gareth got other important duties on adoption leave, so I've drawn the short straw. So I'll chair the meeting today. Now, we're supposed to have colleagues joining us by webcast. Do you know? I can't see them. No, we can't see them. They can see us? Yeah. Right, okay. So there are colleagues who are joining us by webcast. That's me. Moving on quickly. So there are colleagues joining us by webcast from Western Isles, and Jennifer Reid joining in as well. Oh, good, good. Health Scotland colleagues are going to live tweet the events today as well. Anything from here? So and this is Health Scotland Immunise Scot, and also as you can see, you can actually tweet yourself, and the hashtag address is there. But these are also available in your own table if you want to, if you're Twitter minded. So by all means tweet anything that you feel that interesting. And also there's a Twitter address there as well. In addition, what you can do, you can actually pose some question to us on live as you go along by using the Slido, www.slido.com, and a colleague sitting here she'll collate all those queries and questions, and we'll pick them up to the discussion as well. So we've got plenty of opportunity to interact with the chairs and the speakers as well. So you can, as I say, use the Slido. You can actually download the Slido in your smartphone, or if you've got a laptop, we can get it to the laptop as well. Now, because we are doing webcast, obviously the event is being filmed because so that the colleague can hear and see us. And also there will be some photography taken for the social media. So if anybody got any objection to filming and photograph, please tell us, raise your hand, speak to one of the colleagues in the back from Health Scotland as well. And there are lots of material available in the foyer, communication material developed as part of the Scottish Immunisation Programme led by Health Scotland on different languages and so on. So by all means, browse through those as well. And I think that's all the domestic I have to tell you. Other thing is that you're not expecting any fire alarm. So if you hear any funny noise, run for cover. There's one there, the exit over there, another exit on the other side. And I think most of you have seen where the toilets are anyway, just outside the room. And the lunch will also be provided where you had the tea and coffee this morning as well. Anything else have I missed, Heather? Good, right, moving on. Now, although I'm chairing the meeting this morning, I thought it would be quite useful for me to set the scene because I know that I recognize quite a few of the colleagues around the room. A lot of you have been involved in immunization for some time, and some of you are coming new to vaccine transmission program. However, quite a number of faces who are relatively new. So I thought it would be quite useful to actually give you some of the background about how we organize immunization program in Scotland, or at least until 2018, and what is it, why you are doing VTP, why and how. So I thought that will set the scene for subsequent speakers. And what we're going to do also is that we'll take discussion, with plenty of time for discussion at the end of each session. So we'll speak, three of us, and then, as I say, we'll take discussion. So if you've got any question, please just hang on to it. So if this, what I'm going to say is pretty basic for you, apology, but I think it will be quite useful for people to see the whole thing into context to set the scene. So just to go over quickly, as you know, until 2018, we got a number of immunization kind of stream. There are four main ones. We've got the childhood program, which are mainly the routine program for under 5. We've got the 2 to 5-year-old flu, again, for under 5, 2 to 5-year-old. We've got the school-based program, and we've got the biggest program, which is general practice-based. Now, these are different because if you look at the two blue ones, these two are call, recall, and coordination are done by the health boards, HSCPs. All the call, recall for the pre-5 done by SIRS, and for the school program done by the school child health system. And what happened in the first one, although the call, recall done by the health board, actually service delivery model was slightly different until 2018, is that it was used to be the delivered, apart from Lanarkshire, who moved some years ago to community clinics, used to be done by the individual GP practice. But majority of the staff who delivered the program were employed by the HSCP or the health board, about 75%. Whether this one is primarily, because that's only came in 2013, it is primarily done by the GP practices. Although there is a national letter going out telling parents to go to their GP to make an appointment, actual call, recall, and more importantly, recording of the data is done in the GP system. And also the extracting of the data by HPS is done from the HPS, the GP system. It's quite important because, as you'll see, as you're moving away from it, it will have significant knock-on effect on the IT. For the school program, again, usually it's same as the child health program, the coordination call, recall by the health board child health team, HSCP staff, and actually all the staff who deliver the program at school are also employed by the HSCP stroke health board staff as well. But the biggest program, as you'll see, is the adult program covering pneumococcal, flu, shingles, and so on. And these are primarily relying on the GP IT system. GPs do call, recall. Again, there is a national letter goes out for the over 65, telling them to go to their GPs, but all the other call, recall, recording, and has done the GP system, and the extraction of the data also in the GP system by HPS to monitor the uptake rate. So I think it's important for you to understand the differences in how the vaccine was organized until 2018. Now, on the whole, when you speak to colleagues, again, I was invited to speak to a conference in Manchester, and a colleague from Public Health England came to see me and said, "Are you mad?" That's what you mean. I said, "Are you mad? Why you are changing the system been working for so long? You should always remember if it's not broken, don't fix it." I said, "Well, that's where we are." So I think it'll be useful. The reason why they think we're mad is this. If you look at the data, these are the uptake rate data, the quarterly uptake rate data going back last 4 years for the pre-5 childhood immunization program. And as you'd agree that our childhood immunization program is a very successful program. Got uptake rate about 97% for most of the vaccine. Although there is a slight drop over the last few years, probably about 1%, 1.5%, probably due to all the background noise from the social media about the anti-vaccination group and so on. But overall, it is an extremely successful program, probably one of the best in the world, UK-wide. The 97% is pretty good. Apart from, obviously, the bottom one, the green one is called the rotavirus. Again, those of you who may not be familiar with the rotavirus, this is a vaccine introduced 2013. The problem with the rotavirus, they're about 4 or 5% below the vaccine, is that this is a very limited the schedule, because unless you give the first dose by 15 weeks, you can't give it to them again because of the contraindication. So unless you can get the vaccine done, it's given at 2 months and 3 months, unless you can get the babies in before the 15 week to get the first dose, and the second dose must be given by 6 months, you simply lost them, which means that unless you bring those babies on real time, they are not going to get the vaccine. And that's why there's the difference of 4% there, because those babies, although they get caught up by our system later on for all the other vaccine, but they can't get caught up for rotavirus because it'll be too late for them, because they can't get them. And that's why the difference is. And again, what we can do as part of the BTP, use the uptake rate for BTP, the rotavirus, or the gap between the rotavirus and the other vaccine as an indicator of how well we are doing giving vaccine in real time. So that could be an indicator for the new service to see, are we doing any better or worse than what you've been doing until now? Because if you can reduce that gap, it suggests that babies are getting vaccine in real time. It's important because rotavirus may be just a mild infection for majority of the cases, but remember, if they don't get the rotavirus, what else they're not getting? Meningitis B vaccine, because meningitis B, the peak rate of infection at the age of 5 months. Therefore, if they're not getting rotavirus, they're not getting their man B, which means that they remain at risk of man B infection at the peak of their infection risk. Therefore, it is critical that we reduce that gap and get babies in real time, not wait until they get caught up by opportunistic immunization. And again, if you look at the data, these are the data, Scottish data by SIMD, the Scottish Index of Multiple Deprivation. And again, if you look at those who are most deprived and least deprived, these are at 24 months. And what's happening here is that our system is catching up with those babies who haven't had the rotavirus. And as you can see, the gap between those who are SIMD 1 and 5 is very, very narrow. So immunization is probably one of the best way to reduce inequalities in health. Look at this, only less than 1% between those. So that's a very good example of how our system actually until now been doing extremely well on this. So what you have in the routine program is that your program is very successful with very high uptake rate, partly due to the ease of access to target group, because babies, parents just bring them to the clinic, unlike teenagers who are out there doing things they shouldn't be doing, but that's another matter. And also parental motivation for protecting their babies as well, because obviously they're very concerned about the newborn bundle and they want to protect them, and majority of them do anyway. And that's why you got very good uptake rate. And there are very little variation in uptake between practices and also by social deprivation, as I've shown you already. And we got a very good standardized call recall coordinated by locally by NHS board, but also nationally, the national program IT system that we use. And there's an equity of access to vaccination service. So I think it's probably one of the best programs that we have on the immunization side. If you move on to the school program, again, these are the uptake by primary school for the flu, couple of years old. But again, the data will be very similar for this year. But again, as you can see, this shows by the health board. On the whole, uptake is about 73, 74%. But there are some, most health board are around 70% margin. But there's some variation between health board, but not huge variation. These are the HPV uptake rate, again showing by SIMD for girls by S3, first dose, second dose. There are, as you can see, as they get older, the gap between SIMD 1 and SIMD 5 get wider. And again, I'll tell you exactly why the case is. Again, you probably know that. As you can see, the gap is slightly wider uptake rate, but on the whole, probably UK probably got on the highest HPV uptake rate in the world as well. So we're doing reasonably well with the school program as well. So the school-based program, again, we got very standard service across all the NHS board, because most health boards got a school immunization team or got immunization team going to school. We got standardized call recall and mop-up coordinated with the NHS board. What tends to happen is that they call them at S1, S2, whenever they're due, and then continue to call them at S3, S4, S5 every time they go to school until they leave school. And we got very good uptake rate with approximately 75% for flu and 93% for HPV first dose. However, the uptake gradually drops with more SIMD variation as the vaccine is given later years due to absenteeism from school, because they are, by the S3, quite a few of them, unfortunately, don't attend school. And also, there's less opportunity to mop up, because if you got S1, you got 4 years of mop up. But if you start at S3, you only got 2 years, because quite a lot of them leave at S5. So these are the school-based program and the pre-5 routine program. I now want you to contrast with the programs that are coordinated by general practice. Now, this is the uptake rate for 2 to 5-year-old flu. The current uptake rate is roughly about 55%. But that's not, to me, that's not the issue that I want to address. What I want to address to you is that these are about 100 practices in Scotland. What I want to highlight is the variation in uptake rate. If you look at the top 25% of the practices, they're excellent uptake rate, over 70 to 100%. Vast majority, about half of them sit in the middle. But if you are a patient of these practices, about 25% of the GP practices, uptake rate is half compared to those top half of the practices. So we've got huge variation in uptake rate in 2 to 5-year-old flu. Again, these are primarily call recall done by GP practices themselves. This is the flu for adult, the at-risk under 65, exactly the same picture. Uptake rate on average about 46%. And again, in fact, it's gone down since then. Again, look at the huge variation. There are excellent practices going on at the right side. There are vast majority in the sitting in the middle, and there are significant, not just small numbers, significant, about a quarter of the practices. If you are unlucky to be a patient of this group, your chance of getting the vaccine less than half compared to those who are on the top 25. And so every vaccine you look at, this is shingles, every vaccine you look at, which currently rely on coordination and call recall by primary care, you got exactly the same picture. Why is this? So, general practice, usually uptake usually poor. There are significant variation in approach in organizing clinics, including call recall by individual practices. There are huge variation in uptake rates between practices because the challenges of standardization. There are excellent practices going on in some of the practices. There's no doubt about that. But unfortunately, you've got a significant minority who are not doing this. So there's challenges of standardization across the piece. There's inequity of access to vaccination service. And what happened was in England, a few years ago, they did a huge study inviting every GP practice in England, and there was very good uptake. Over 800 practices took part in the study. What they found was that, and they tried to understand what are the key factors which led to this variation in uptake rate and the poor uptake rate. What they found was that almost all the issues are practice specific. The uptake rate is not low in some of the practices because they come from the social deprived area, because we got example in Glasgow and Clyde and other health board where practices practicing from the same health center got uptake of 20% and 80%. So it's all to do with how the practices are organized year on year in calling, recalling, and inviting the patient. So most of the issues that affect uptake rate from the biggest study probably that ever done in the UK shows that most of the issues are practice specific, not patient specific. So what are the key challenges issue affecting general practice? Again, most of you are familiar with this. There have been significant increase in vaccine workload and complexity of schedule in recent years. Now, I said to Joy, I was going to use a slide which basically shows all the vaccine that we introduced in the UK since 1796, because that's when Edward Jenner demonstrated that by giving some material from cowpox, you can protect against smallpox. But Joy, I just found it yesterday, Joy is using the slide, so I'm not going to use it, so I'm not going to steal her thunder. But just a key point is that if you look at that slide later on, if you look at how many vaccines, how many changes we made to the vaccination program, the number of changes since the millennium, 2000, were same as for the last 200 years. So you can see the extent of the changes in immunization program for the last 17, 18 years. Almost same as what they've done the last 200 years. So there's huge changes and the huge increase in workload. And all we do every time a new vaccine comes in, GPs. And quite often, GPs bring in some extra resources for the practice nurses. The practice nurses quite often has to just add on their workload. So the whole system is becoming overburdened with the immunization services. There is also recruitment and retention crisis in primary care. Again, most of you are familiar with this, with unsustainable workload. And the GP is also changing their role to become the expert generalist. So what happened as part of the negotiation with the SGPC, the Scottish GP Committee with the Scottish Government, they wanted to basically look at or explore services that could be delivered the other bits of the NHS system to release some of their time so they could concentrate on other area, including chronic disease management and so on. And that's how the vaccine transmission program was mooted, and that's how it came into being, that we can look at how we can actually find delivery of some of the program delivered by GPs through other system as well. So again, the VTP to be implemented, it is the implementation is coordinated by the Scottish Government with input from all the NHS board through the BCM steering group. BCM is the business change managers. So every health board got a business change manager who joined the steering group, coordinated by the Scottish Government. And the BCM steering group got a number of the subgroup as well. One on IT, communication and engagement, who is involved in organizing this seminar, the travel health, workforce, and so on. And although it is a 3-year phase program, it's supposed to be fully up and running with the complete transformation by 2021, the most important thing is that we are not going to take it away from GPs until there is a safe and sustainable alternative service available. Because that's the MOU with the SGPC. If you're not able to deliver the alternative model, it stays with the GPs. No matter what the GPs tell you, that's the deal. The Scottish Government is quite clear. Until we can replace the whole thing and provide a safe and sustainable model, it will remain with the GPs. You're shaking your head. I'm sure we can discuss it. Well, I can assure you that that's the line the Scottish Government currently hold, and there may be vaccine, and I'll come back to it later, where we'll not be able to transfer over, particularly shingles, for reasons I'll tell you, because it's not going to be safe to do that. Second point is that, remember, as part of the overall primary care transformation program, there are certain money has been made available to HSCPs and IAs and primary care. It is important that BTP is one of the 6 work streams. It is important that you do need to invest into immunization. It's simply not going to be that, unless you invest resources properly and provide a robust and flexible service, we will not be able to improve those services. But there are huge opportunities, as you'll see in a minute. Obviously, most of the work of local delivery will be done at the board level, working closely with all the stakeholders, HSCPs, IAs, community pharmacy, and others, all the stakeholders in the board level who are involved in delivering the program. And that's what the most of the key work need to be done. So what are the key challenges of BTP? I think one of the biggest challenges they're going to face is the availability of the appropriate IT system to identify those who are at risk, call, recall, and record the data, and more importantly, sharing the data then with primary care as well. Because, as I said to you already, both the 2 to 5-year-old flu and all the adult program, the current call, recall, recording, and data extraction are done by the GP IT system. And we take the immunization away from GP practices, we're not going to have access to their IT system. Unless you somehow can magic give us access to it somehow. So I think that's going to be the biggest challenge, as well as resources. Obviously, the funding has been given as a block funding from the Scottish Government to the whole of primary care transformation program, and it is important that the vaccine, the BTP, get its share of the resources to be able to deliver a safe and sustainable service. So it is important that the vaccine gets the priority it deserves. And obviously, when I speak to some of our HSCP directors, the chief officers, they tell me that the amount of resources given to primary care is not going to be enough. Now, well, if that's the case, they need to negotiate with the Scottish Government for more resources. That's not above my pay grade. So it is important that we get the resources that we need. Not forgetting a workforce capacity. At the moment, a lot of these are delivered by the practice nurses and others. So it is, we can't just magic a lot of extra nurses, because they need to identify the workforce, train them up, and also capacity of infrastructure. I mean, even when you try to identify a clinic for the pre-5, we struggle to find accommodation for them. So I don't know, the infrastructure is there to be able to provide alternative delivery model as well as alternative capacity and the accommodation as well. And there is also the concern about the fragmentation of the service, because as you all know that if a mother turns up with a toddler to a GP for something, GP can ask, well, have you had this child vaccinated? They can do opportunistic immunization. And there is this concern that actually with the new model, that might suffer. Again, we don't know. We may have some early data, but we don't know exactly whether by not or losing that opportunistic immunization, whether it's going to have a negative impact on the vaccine the program. Having said that, I'm always a glass half full person, so always look at the opportunity as well as the challenges. I think there are huge opportunities for us to significantly improve the vaccination service in Scotland, as well as supporting the evolving role of the GPs as intended. We can provide standardized adult and pre-5 flu vaccine service with standardized call recall, which are not currently the case. So there are a huge opportunity if we are willing to put the resources in, get the IT sorted eventually, and do the standardized call recall done exactly the same way we do for pre-5 children as well as for the school program. Working with the general practices, we can increase vaccine uptake and reduce those variation and improve patient safety. Surely, in the days of our CMO promoting realistic medicine, and one of the key things about realistic medicine is to reduce variation, it's not surely acceptable that some people got uptake over 20% practicing same side by side another practice about 80-90%. So our key other thing we're going to look at is the reduced variation, improving tribal health service provision. Again, I don't have time to go into the details, but the tribal health provision is very patchy, depends on who you are, where you are, and this is the one service the GP practices wanted an alternative model as well, and there are some work going on nationally and as well as locally trying to find alternative delivery model to make sure that everybody in Scotland at least got some basic access to tribal health service as well as more expert service as well. So I'll stop here. Just hopefully that will give you the background exactly where we are before we moved to the BTP. I'll pass on to Joy, and we also got not Linda. Linda is unfortunately on jury duty, but we got Kerry Wallasey from Dumfries and Galloway as a primary care transformation manager who will speak. Then we'll have a discussion. But in the afternoon, we'll also hear colleagues from all the health board in the west of Scotland tell you exactly where they are and some of the challenges they are facing locally to deliver the BTP in their own health board area. So without further ado, I'll pass it over to Joy, who is the Director of Public Health in the Ayrshire Island Health Board. Thank you.
Okay, there we are. So, good morning, and it's great to be here, and it's great to be able to, I think I've got the most fun bit of this morning, just to be able to reflect on some of the really positive achievements that vaccination has brought to us all. And from a public health perspective, obviously the population gains as well as benefits to individuals. And it's become such a core part of what we do. I do wonder sometimes if we fully appreciate all of the harms that have been avoided. So what I'm going to go over this morning is just a wee bit of indulgence, a wee bit of looking back to see what vaccinations achieve for our population, and also a little bit of history and what we can learn from a personal bit of history as well as from the wider population history. And then a bit of reflection about the challenges for the future as well, just building on some of the things that Syed has mentioned earlier on in his talk. So why does it matter? Well, fundamentally, and I know we've got a spectrum of people here who are absolutely embedded in this, but just to wind back, because there are people who are just at the beginning of their journey of involvement in vaccination as well. This is about control of infectious disease. That's the whole purpose of vaccination, and our schedule within the UK as well as in Scotland is to make sure that we have one that is safe and effective and it protects children and families now and in the future. So it's building on everything that we've done up until this point. And I was looking for sort of pithy quotes in advance of that, as you do. And there is controversy about vaccination. What's its relative contribution to human and animal health? But it certainly is sizable. It's made a huge step change. We are not losing infants in the way that we were back in the 1800s or even earlier this century. It's made a huge change in infant health. And I really like this one in red, that vaccines are the tugboats of preventive health. So to me, it's a deliberate, skilled job of nudging every single day, making sure that things are delivered precisely to make sure that individuals are protected in a timely way. And so that was the one. William Fogey is an epidemiologist from the 1970s, but that was one of the things that people have said about vaccination. If you're trying to go away with a message, I like that one, because it is about deliberate hard work, skilled hard work to make sure that people are protected at individual and population level. And we've made huge gains as a human population with the eradication of smallpox, which was a horrific illness with very high case fatality, killing roughly 35% of those who were infected. And there was a deliberate worldwide campaign of an effective vaccination programme which actually resulted in eradication of that condition worldwide. People do not die of this anymore. And the only time we worry about it is from a CBRN terrorism point of view, but let's park that. And polio, in a similar way, feels as though it's almost at the tipping point of eradication as well, but it's been stuck a little bit for various reasons. In the UK, we used to have regular outbreaks of paralytic polio, which were devastating, and some of us in this room will know of individuals who've recovered from that awful condition. Roughly 8,000 cases per annum in the UK when polio outbreaks were happening. And the picture at the bottom, I made it too wee, I think, in retrospect, but that's the sugar lumps, and probably most people in this room will remember that from when we were all at school, and you would get this slightly pink tinged sugar lump to crunch on. It's part of all of our histories, but the success of all of us being treated when we were children and having those sugar lumps isn't just that we love sugar. It's also that we now in the UK haven't had any wild cases of polio since 1984. There are occasional cases maybe imported, from other countries, but we haven't had any de novo cases in the UK. Huge success. And 8,000 cases per annum avoided of harms. This is the personal journey bit now. So,
Baby Tomlinson.
Yeah, this is Baby Tomlinson's card. I don't know what my mum did to this card. It's clearly some water damage. But I suppose there was two things I wanted people to note about this card. One is that we haven't always actually relied on GPs fully, even within the NHS service, to deliver childhood vaccinations. This was a child welfare clinic set up when I was a babe, and going to the Millbank Centre in Cumnock. I don't know how well you can read the hints for mother section at the top there. Cleanliness and tidiness in a person and home are the hallmark of a good mother. There are other pithy comments inside the card as well, not all of which were wrong. Breastfeeding's right up there as something you should be doing as well. But the bit in red was the other key message I really reflected on, as thinking about my own journey and all the protection that I've had as an infant. Babies should be immunised against smallpox, whooping cough, diphtheria and polio. And I have been vaccinated against smallpox. It tells me inside on the 31st of March, certain year. So I've had that. And even when I was a babe, there were controversies. There have always been controversies and miscommunications with the public. There were all sorts of problems about whooping cough, which was a wholesale vaccine at that point as well. And many mums decided, don't want my babe to be put in those circumstances. It's a different vaccine we now, and it's different controversies that we have. But that need for clear communication has always existed as well, and we can learn from the past about ways that has been done. So that was me. So this is the slide that I pinched that Said wanted to use as well, and it does say Public Health England at the top, but it's a UK schedule, it's a UK story. So right at the very top, I think people at the back can probably see it. It's 1796, development of the first smallpox vaccine. That's how long vaccination is part of our journey, and it's been with us, and we do take it for granted. And that's a good thing in some ways, but we have to remember that. And then you can see, I wanted to also draw your attention, because I'd mentioned polio, introduced in 1956, the inactivated polio vaccine, right in the green section over there. When you look back in history, the uptake of vaccination really took off with the introduction of the NHS, when we had that introduction of a universal healthcare system. And while in the past, certainly from the 1930s, we were starting to see benefits, we really saw a step change in population health when we got that universal coverage. And I think that was another key message, just reading back over history for me, that we need to remember as we're looking to transform at all. And as Saira said, the number of changes which have increased in recent years, much, much greater than we've had in the past. As we're learning more about microbes, and as we're learning more about the impact on, the best way to inform our immune systems so that we're ready to respond to whatever comes our way. So there have been a number of significant changes since the 2000s. And it's quickly assimilated into all of our minds about flu, but actually seasonal flu was only really part of the schedule from 2000, just for the changes between green and red on the snake chart. It already feels like, of course we would always do that, but it's not been all that long, really. And this is, I suspect, familiar to many people in the room. This is the routine childhood immunisation schedule. And as we have it at the moment, and I suppose the key messages that I wanted to highlight for this, for me, is that it's very well defined. It's robust. It's scientifically understood. And we have a robust call-recall system. It is complicated. There are key time intervals which we absolutely have to adhere to, otherwise the vaccines don't work, as Syed has just explained. But we do have a really good understanding of what needs to happen for the best population coverage. And that does put us in a really good position to think about any transformation process, because we know what we need to do. And this, again, was just to highlight the changes that have happened, in particular in the last 5 years. None of these have been small. Rotavirus being introduced, flu vaccine for children, the meningococcal ACWY vaccine, and MenB vaccine, and various changes. There are other things as well that have happened with the HPV vaccination for men who have sex with men as well. And while I haven't mentioned phased rollout and all of those, there's been an ongoing process with a number of the vaccinations. It's not just, right, that's it, it's fixed. It needs to be embedded. It needs to be taken into our systems to make sure that we haven't got any problems and that we've got that coverage. So herd immunity is often used, and as a description of the benefits that the population gets from vaccination. So every individual who receives vaccination absolutely has a personal benefit, because when a bug comes along, you don't get it. But there are some individuals in our population who cannot have vaccination because they're too young, they're too old, or they may have underlying health problems. And the benefit of having high uptake does need to be emphasised, because it provides protection to those individuals in our community who are more vulnerable to illnesses and can't actually receive vaccination. And the example I wanted to pull out here is measles, because it is highly contagious. As a number of people will know, there's an ongoing situation in a certain New York state who declared a state of emergency yesterday, and they have banned all under 18s who are unvaccinated from going to public spaces for the next month. Can you imagine what that would do to our education system if we were to experience something like that here, just like that, because the vaccination levels have unfortunately dropped below the protective level in the population? High uptake is really important, but I've added that final bullet point in the bottom, because not all infectious diseases are stopped by herd immunity, and we certainly can't rely on it. But it does give that added layer of protection to the whole population. And just to take forward the measles discussion a little bit more, we've made huge inroads globally. The chart at the top on the right-hand side, your left-hand side, that's right, shows uptake of measles vaccination in the dotted lines. There's estimated by official numbers and the WHO numbers, and also the number of cases worldwide. And you can see as vaccination has increased, the number of cases has come down in a very pleasing fashion across the whole of the world. But measles remains a really miserable condition, and I haven't seen a case since I was a child. I do remember playing with a next-door neighbour who was recovering as a child, because I was vaccinated, as we know, from measles, and they were miserable. It's a horrible illness, and there's a risk of trivialising some of these vaccine-preventable diseases, of playing down that, oh, it's a disease of childhood. But actually, measles epidemics in the past were a real pressure on general practice, with outbreaks and dedicated follow-up and support and antibiotics needed for those children who had gone on to develop complications. And I suppose that's the other message for me. Primary care and public health are very closely intertwined. When something goes wrong in our world, it quickly impacts on the frontline services as well. And there's a definite win-win that we need to have sight of here to make sure that whenever the transformation happens, that we maintain population coverage so that we're actually also protecting our frontline services. And this is the Scottish figures. So I did hear a little, in my imaginary mind, I was thinking, aha, that's the global figures. But what's happening here in Scotland? Well, we've had fantastic success in terms of the number of cases with measles. in recent years. So this is Scottish laboratory-confirmed cases of measles in Scotland from 1988 to 2018. And I've pinched this off Health Protection Scotland's website, of course, great source of information. And it shows where the MMR vaccine was introduced, when we introduced a catch-up campaign, which was measles rubella, when we had that spike, and then the second dose of MMR being introduced. And that leaves us to the happy situation of where in 2018 we had 2 cases of laboratory-confirmed measles in Scotland, which did not lead to an outbreak, because we've got fantastic herd immunity and we've got that protection in the population. Ah, yes, this is the audience participation section. Yes, this is my rose. It's called Robbie Burns, just in case any of you were wondering. Now, when you came in, I randomly assigned some coloured dots to people's badges, just to be friendly. And some of you have blue, and some of you have yellow, and some of you have none. And if you have no dot, then you are immune. Isn't that good? If you have a dot, you're not immune. Oh, and we have a traveller with us in our midst, don't we, Elvira? Yes, there we go. Elvira's just come back from New York State, and she has a yellow dot. She actually hasn't been feeling that good, have you? No, I didn't think that, no. So what we're going to do is just a tiny exercise in herd immunity for fun, just to see how far this bug might spread. Now, actually, measles is incredibly good at spreading, as we all know. So this is a slightly dubious way that we're going to demonstrate it. But basically, I think Elvira might go for a walk and just randomly touch people. And if you're touched and you've got a yellow... No, you don't do that, no. If you could stand up, just so we get the visual here about how far this could spread with somebody with measles just walking through the room. So... No. Up. Yeah, and you are now to touch people too. Oh dear. Yay! Now then, so our new people, you are also allowed to touch who you're near. There we go. Stay. Oh no, Elvira. Well, yes. Have you recovered now, Elvira? Yes. You're quarantined. Okay. And there are 3 people, I think, who've got blue dots in the room. And you are too young, too old, or unwell individuals who couldn't be vaccinated. There we go. So it was just a bit of fun. Let people go back to their seat. But if people could just put their hands up if they were tapped on the shoulder and ended up with measles, just for infected people, hands up. Yeah. And were any of our infected people, have any of you got blue dots? Did we manage to protect the blue dot people?
A blue dot, but he didn't get infected.
Oh, did he not?
Blue dot was.
Blue dot's too young, no, or too old, or unwell. So we were trying to protect them, but...
So he was lucky.
Okay, he was very lucky. Okay, but it was... And all of those individuals would be a pressure at the front door. That was basically the take-home message from that. And the other bit of my rose, of course, I do like gardening, and there's a wee reference in the bio to that as well. So tetanus, you get no herd immunity. So I'm protected against tetanus and my happy gardening experiences from all the thorny roses that I deal with. Every time I go out there, I'm safe because I'm immune to tetanus. So these individual ones, there's absolutely no herd immunity from, as many of you know already. So anyway, challenges. So just to wind up, and I suppose to think about the challenges going forward, no matter what or how we deliver our vaccination programmes, there will always be concerns about how do we maximise access across the whole population, particularly amongst people who are more mobile and maybe we don't have good connections with their GP practices or whatever the call-recall system is. So we do have opportunities where we might be able to improve on that, and we should always be challenging ourselves about that no matter what system we have. There are subgroups in our populations who we know are at higher risk either of particular diseases or because of their own circumstances. And these subgroups often will benefit from more targeted approaches. We might have to think about doing things slightly differently for them. And we do need to keep always an eye on what is happening in informal communication routes, either through social media, as it is these days, or rumour mill, perhaps as it was maybe in the past, just by word of mouth and people expressing concerns. And whatever delivery mechanism we have in the future, it needs to be tightly communicated, transparent information that gets to the public. And how we do that needs to be consistent no matter what diversity we have in terms of the delivery mechanisms across the country. And in terms of who delivers vaccination, I suppose it is both a challenge and it's an opportunity. I've said it's a complicated vaccination schedule, and it is. It's not complex, though. We understand it. The deliberate pacing and separation of vaccination intervals is nationally agreed and well understood, and it's working. So we are in a good place to take on any new challenge about transformation. As we've heard, there is variation in uptake, particularly about some of the vaccination programmes, and there is a challenge about, particularly when we come to implementing changes, to make sure that that's done consistently across the whole of Scotland. But we are in a good place to be able to do that. The health and social care partnerships and the approaches that they're taking to transform primary care, it feels like the right time for them to step up to the mark. Certainly they're saying that, you know, we understand our local area, we understand the geographies, and we're ready to try and think about this new challenge. So it feels as though we are in a good place to do that too. And perhaps there are opportunities to learn from the past, to think about the child welfare clinics, the other ways that we've done vaccination in the past, to make sure that we can think about and learn from that for the future. Oh yes, I'm going to skip over this one. Basically, there will always be change. This is the message here. And we will have to be ready, whatever system of delivery is in place across Scotland, to adapt and change to the national requirements as we learn more about bugs and we learn more about the best way to protect people. This cannot be a frozen in aspic delivery mechanism. And so my closing thoughts are, I suppose, really to remind everybody about the achievements that vaccination has brought for us, but also a word of caution that microbes do not care. They are microbes. If we let our guard down, then outbreaks will come back, and we will find that there is avoidable, vaccine-preventable disease happening again in our communities. And I think we need all to be mindful of the ongoing dedicated tugboat approach to prevention, the deliberate, skilled intervention that's needed to make sure that our population and individuals are continually protected. So, there you are. I'm going to leave you with those thoughts.
Thank you, Joy. Thank you. Now, as I say, we'll take question at the end of the three presentations. So, the last of this morning session presentation, or before coffee, is Kerry. Kerry very very bravely kind of standing in for Linda. So Kerry is the Primary Care Transformation Manager in Dumfries and Galway.
That's right. Thank you very much. I hope I will get the sympathy vote today for arriving with someone else's slides to present to you. Thank you very much for the opportunity to come and speak to you today. As was mentioned earlier, my colleague Linda Bunny, who some of you may know, was called up for jury duty earlier this week, and unfortunately is still required today, so you have me in her stead. My name is Kerry Willisey. I am the relatively new programme manager for the Primary Care Transformation Programme in Dumfries and Galloway. And I'm here today really to give you a perspective from primary care as we come to the end of our first year of implementation of that primary care transformation programme. So in the next 10 minutes or so, I hope to give you a flavour of really how we are seeing vaccination transformation activities in Dumfries and Galloway, and identify some of the great benefits as well as some of the challenges that have come to light over the past 12 months or so. But first, I think in order to understand some of those benefits and challenges, it's important to understand the context which we are operating in Dumfries and Galloway. Is that going to work? So in Dumfries and Galloway, we have 4 clusters and 4 cluster groups with which we are working very closely, not just in the primary care transformation programme, but also very closely in terms of vaccination transformation. The 4 clusters are at various stages of maturity, and they are all quite different. We have different individuals who sit around those cluster tables. Some are GP only, some are GP practice managers, and some are much more representative of the wider multidisciplinary teams that we are trying to build. We recently undertook the General Practice Sustainability Assessment Tool exercise with all 32 of our practices in Dumfries and Galloway, and that's really given us some key indicators and an assessment of where we are starting this process from. So in Dumfries and Galloway we have 32 GP practices, 3 of which are 2C board-run practices. In total we have 107 GPs, which represents 88.1 whole-time equivalents. But this is when it starts to get quite scary. 16 of our 32 practices, or half of our practices, have vacancies, with 13 of those practices having had vacancies for over 6 months. And 7 of those practices also have satellite branches. In terms of vaccination transformation, we have 7 yellow fever centres which are placed right across our region. But sustainability is a really key element of the work that we are doing in Dumfries and Galloway, as well as transformation. It's very important that we are keeping the lights on in the practices that we have. So what did the sustainability assessment tell us? Well, 6 of our practices out of the 32 are run by a single-handed GP, and 5 of those 6 are run by individuals who are aged 50 or over. Another 9 of our practices are operated by 2 GPs, and 7 out of those 9 have at least one of those GPs who are aged over 55 years or older. So there's a great potential for at least some of those practices to also become single-handed in the coming years. 3 practices are run by single-handed salaried GPs who are employed by Dumfries and Galloway, and all 3 of those individuals are aged over 50. So this analysis really hopefully gives you an appreciation of the extent of the sustainability issues that are facing primary care in Dumfries and Galloway, and I'm sure in some of your areas as well. Resilience is a key concern, and this really relates very much to how VTP is seen in our region. So as has been mentioned already, the question is often, why are we trying to fix something that isn't broken? But we have to look very much at the longer term, at the 5 to 10 year mark, because what we have at the moment may not actually be what we are going to have in 5 or 10 years' time. And very much our practice nurse, ANP, and other members of that multidisciplinary team have a very similar age profile. So what we're looking at is an ageing profile across all roles in primary care. And that's something that we've got to be very mindful. We're not just trying to fix the problems of today. We must look slightly further ahead to ensure that the transformation activities we're doing are not merely just plugging holes for the next 3 years or so, that they're actually trying to sustain us a lot longer into the future. So taking that in mind, what are the GP perceptions of the vaccination transformation programme? Generally, as I'm standing here today, the programme is seen as extremely positive, though it has been a journey over the last 12 months. We now have most of our practices signed up to the plans that we have. We have one outstanding, and I think that one is really just waiting to see how things go. But as I stand here today, I'm extremely proud that we have that buy-in, because there has been a lot of conversation around GP cluster tables and around our GP subcommittee tables as to why this activity is being undertaken at all. We are building a good level of trust between the GPs and ourselves in primary care development and with the NHS board. It's a very different models that we're looking at in both of those. GPs are able to implement change almost instantly, whereas, as you know, we seem to find ourselves writing endless reports and appearing in front of endless committees and boards in order to get funding and to get approval for things to move ahead. But that's coming, and that really, it's something that I think we can be immensely proud of. There is a feeling, and there has been a feeling, that the VTP programme has been moving quite slowly. Part of that is to do with the need for the wider primary care improvement agenda to catch up with the vaccination transformation programme, which was streets ahead of where we were to start with, and it has just taken that little bit of time for the funding and the planning to catch up with where the vaccination transformation programme is. But again, I stand here today and I think we've made great strides over the last few months in particular about that. In Dumfries and Galloway, about 66 of our GP practices are already receiving an NHS board service in terms of their preschool vaccinations. So that has given us a very strong foundation in which we can look forward to building a vaccination service around that strong beginning. But looking to some of the concerns, there's great concern in our area about the continuity of payments and how that's going to work. We touched earlier on around the opportunity for opportunistic vaccinations, and there's still a lot of questions about how that could potentially work in the future. Practice nurses are another key component of our primary care teams, and there's great concern that they will feel a great loss of ownership, particularly for some around travel health. We have some practices that cannot wait to get rid of their travel health responsibilities, but by the same margin we have others who have built up a great amount of experience and expertise in that area, and that's something that, if taken away, will be really felt by those key individuals. And what we don't want to do is force them into considering retirement if that role potentially isn't there for them any longer. There's also been some reflection that the model may be suited to urban areas and not as easy to implement in very rural areas. I think Dumfries and Galloway probably comes to all of these types of events and says that, but I think that's something that has been reflected in some of the conversations that we've had around those cluster and GP sub-tables. And again, it comes back to the question of, it's really not broken in Dumfries and Galloway, so why are we trying to fix it? We're very fortunate that our take-up rates are extremely high in our area, and there's great concern that any change would potentially have a negative impact on that. So, if we start to have a look at some of the benefits and challenges that have been identified from that, you can see that I've mentioned some of the benefits already, so we're building on that established model of board-delivered preschool vaccination services. There's really only minor tweaks required to our service level agreement for that. It will release practice nursing time in order to focus on some of the other key elements that is talked about in the wider primary care transformation agenda, so looking at chronic disease management and other areas where more time could be better used by practice nurses. And there's real opportunity for the standardisation of the service. In Dumfries and Galloway, it's delivered quite differently by different practices, and to have a standardised service could potentially bring a lot of benefits. However, and there's always a however, there have been significant challenges identified in the course of these discussions. Primary care transformation is all about releasing GP time, and vaccination transformation doesn't really afford us much opportunity to free up a significant amount of GP time, given that primarily it would be practice nursing staff who would deliver the immunisations at the moment. We've mentioned already the loss of opportunistic vaccinations, and I think we still need a little bit more clarity around how that's going to work in practice. We found it's quite difficult to quantify the numbers of those opportunistic vaccinations, so maybe some of the discussion later on may focus a little on that. There's real concerns about, as I mentioned, a fall in uptake rates. We are looking, I think, in our area to moving to more of an appointment-based system. That's really a reflection of the fact that we have practices that run drop-in services, that at times the police have to be called to try and manage the traffic and parking flows outside because people are queuing down the streets on one particular day to get their vaccinations. And that's not a good use of anyone's time, and we're hoping that by moving to a more structured appointment system we can be much more organised without putting up too many barriers for people to be able to come along and get their vaccinations when they need to. There's obviously concern around accommodation as we're developing these multidisciplinary teams within GP practices. There is more demand on available accommodation space for all of these new NHS employed staff. So we need to be thinking about what other models can we use and what other spaces are suitable for delivering vaccines, and the challenges that are associated with that. There's quite a lot of concern about IT systems, and I'm sure that may be something that comes up later on. We're fortunate in our transformation programme we have a dedicated technology group, and they are looking at very much both at short-term solutions to how we can manage those interfaces between vaccination teams and GP surgery data, but it's extrememely important, and there's developments coming, but they're not going to be coming quick enough for the timescales that we're looking at in this programme. Mentioned about the de-skilling the GP workforce, the nursing workforce, and I think it's very important that as we're having these wider transformational discussions, we seem to be very focused on GPs, but we must also remember at all times there is a wider practice staff that will be affected by this, and we are trying to work very hard to ensure that our practice managers and our practice nursing staff are on the bus with us as we're on this journey over the next 2 to 3 years. Recruitment, I've already mentioned issues around GP recruitment, but there are issues around recruitment of skilled staff in all areas of the transformation agenda, and vaccination transformation is no different. And one of the other issues that's been raised is just around fridge capacity and how that's going to work, and using different spaces and how safe that is. So really just to sum up, vaccination transformation and the programme has been identified as one of our key priorities in Dumfries and Galloway for years 1 and 2. I think that really reflects the amount of work that will have to be done in order to have this in place and being delivered in all our GP practices across the region by April 2021. We're very fortunate to have our team with us today. I think they're mostly at the back of the room if you want to wave. But they're doing a huge amount of engagement activity because this really is a significant change for the GP practices in our region. We fully acknowledge those challenges, but I think we are confident, not overly confident, but nicely confident at this stage that we will be able to fully deliver what's set out in the vaccination programme as part of the 2018 GMS contract within the timescales. But we do recognise that there are still areas of significant uncertainty that need some clarification and some significant challenges as to how we're going to do this in the time. But I'm trying to keep it fairly positive to try and build on what we've had on already today. I know, as I've mentioned, the team are here and we'll be hearing more from them in terms of the detailed plans that they have for taking things forward, particularly over the next couple of years. So that's helpful.
Thank you, Kelly. So I know we're running a wee bit late, but don't worry, we've got plenty of time to spare. Do you have anything from the Slido?
Yes, we do. How are Dumfries and Galloway managing the allocation of funding across all of the PC work streams?
Well, what we did was...
Can you hear from the back? Do you want to come? Do you want to come beside the microphone? So that. Yeah.
Yep. So what we've done in Dumfries and Galloway is we held some workshops in conjunction with our cluster teams to identify 4 main priorities for years 1 and 2. The funding is such that it doesn't really allow for a significant step change of additional activity in year 2. So we identified 4 key priorities. So pharmacotherapy was identified as probably one of the areas that could deliver the greatest removal of GP workload. We also have started work following up from some of our mental health pilots to put Band 6 CPNs into some of our practices to take away some of the undifferentiated mental health individuals who really were tending to be frequent flyers, repeat visitors to GPs and taking up a lot of their time. We're also running 2 pilots in terms of urgent care. So we have a paramedic pilot, which is just coming to an end in one of our most rural areas, which is looking at regular paramedics attending house visits, which are deemed suitable on behalf of 2 of our practices in that area. And we have some specialist paramedics who are also working across 3 other practices. So that's our urgent care, and we're really hoping to work with the Scottish Ambulance Service to look at the evaluations of those to decide how we want to take that forward in conjunction with them. They're being staffed at the moment on an overtime basis, and that will not be sustainable going forward. And then lastly, we've got vaccination transformation. So we took those 4 priority areas and we set up through our Primary Care Transformation Board the opportunity for proposals to be developed through the clusters, and we had a prioritisation workshop with members of our programme board who used 6 criteria to score. It was a little bit like the Eurovision Song Contest on the day, which gave us a ranking which we then passed on to our finance team to develop a kind of financial implementation plan. So that's the process that we used for years 1, really because the activity in year 1 was limited to just 1 or 2 quarters. The implication of that is we've actually probably allocated most of the year 2 funding to those priorities. So we are currently working very closely with our clusters to develop proposals and ideas, probably for December this year, so we can have them approved, start the recruitment process, so we're able to really hit the ground running when we get the next tranche of funding in year 3. So that's kind of where we are right now. Does that answer your question? Yeah.
Any other? No. Okay. So,
Yep.
Any other question for any of the speakers this morning? Yeah. Could you say who you are so we know?
I'm Mark Russell. Thank you. I'm Mark Russell. I'm a GP in Lanarkshire and also a clinical lead in primary care in Lanarkshire. I think we have to be careful about the universality of the messages that we're sending out across the system. And what I mean about that is I think it's important that there are shared goals for this transformation between health boards and between GPs. And this is going back to what Dr. Ahmed said back at the start about regardless of what GPs may tell you about the pace of change. Now, I have the luxury of having the MOU between HSCPs and Scottish Government in front of me. And what it says is that this change needs to be managed, ensuring a safe and sustainable model and delivering the highest levels of vaccination and immunisation uptake. And I think that's probably the bit that you were referring to in the MOU, because it's the only bit essentially about vaccination. There's an expectation which has been sold quite strongly by Scottish Government on the part of GPs that significant work is going to be taken off them over the next year or 2. And I think that we need to ensure that when we're sending messages out at events like this, that we take those messages that GPs have a legitimate expectation that this will happen quickly to ensure the sustainability of practices into account.
Okay, since you mentioned my name, I'll start, and then colleagues from Scottish Government can help me out in this one as well. I fully agree with you, but having said that, as you already heard, year 1 has been difficult. A lot of the health board have struggled mainly because, as Kerry said, and others have said, what happened was that year 1, HSCPs quite often deliberately didn't spend any money on the priority areas because they're waiting to see exactly what are the other 6 work streams going to be asking for the same resources. So a lot of the health board has not had the opportunity to actually put in a lot of resources year 1 to be able to find safe and sustainable model for us to take away a lot of the work that we love to do. So I think that's the one thing. Maybe year 2 or year 3 will you'll probably hear from all the health board in the west of Scotland where they are. And that's our aim. The reason why I say safe and sustainable, particularly I mentioned shingle vaccine. Shingle vaccine is a live vaccine. And there are significant contraindications. Now, primary care struggle to give the vaccine quite often, mainly because they don't have the clinical information, because secondary care don't always communicate to primary care. Imagine us asking the nurses out with any clinical setting, try to deliver a live vaccine. And that's why I said there may be vaccine we may not be able to safely move out of GP practice from a clinical setting until such time. The good news is there is a non-live vaccine licensed. It's probably available in the UK in the next year or two, and we'll be able to take it out then. But until such time, we won't be able to. So that's the point I was trying to make, not because we don't want to take away from GP to support their evolving role. So I think that was the key message I want to get. Do you want to say anything else on this? That's the program manager on the VTP from the Scottish Government Policy Team.
Yeah, hi, I'm Nicola Kerr. I'm not really going to add an awful lot more to what Syed has said. I think one of the things that we also need to keep in mind is that this is not a vaccination transfer programme, it's a transformation programme as well. And the vision we have is that we are actually going to modernise delivery of the vaccination services. Like Rome, it's not something we can necessarily do quickly in order to achieve the benefits that we really want to get from the programme, which is that we recognise that there are areas that we could make a big difference by doing this programme, and we want to be able to ensure that we are able to put in place models of delivery that will deliver those. And again, going back to the safe and sustainable, we have to make sure that what we do put in place is safe and sustainable, because otherwise, we've heard from Joy about, what could happen if we don't. So I think, we're approaching it in a way that's hopefully methodical and structured, and will support the aim of, alleviating the workload of the GP, but will also support a newly transformed vaccination service.
But your point of shared goal is well taken, and I think it's important.
Quickly on that, particularly around the shingles. Thank you. Particularly around the shingles vaccine, I think the idea that vaccines can't be transferred or transformed around safety issues and clinical issues, I think that's an easy sell. I don't think there's an issue around that. Yeah. I think what will be a more challenging sell is if I have to say, as I have in year one, hang on guys, there's a lot of planning to be done here. This Rome can't be built in a day. And if I have to continue saying that for the entirety of year two and into year three. And I think we have made it clear to our GP colleagues that, I think it was yourself that mentioned this, that general practice and health boards are not the same. General practice can change tomorrow. This can't be done in health boards. But I think we're getting to the point now where in year two, we do have to start to see some significant. Yeah,
I think as you'll probably hear from all the health board this afternoon, you'll be reassured by the fact that most of them are progressing quite a lot of work in this area. So I'm sure at the end of the day, you might be better reassured than now. Any other comments or queries of the speakers this morning? Yeah.
Also, Mr. Wynne was in for Slido. But,
for the benefit of everybody, just
okay.
tell us who you are then.
Alistair Cook, business analyst with the Kind Child Health Programme team. So we're looking at replacing current systems of that. You showed national picture of uptake rates for general practices side, and that was national. Are GPs, is there a variance, or is that picture pretty much the same? I know, sorry, is it Kerry? Kerry did seem to mention that maybe there were higher uptake rates in D&G. So is there a varied picture in terms of uptake rates for general practices?
Well, if you look at the childhood program, because uptake is so high, 97%, most health boards run between 95 and 97. But the adult program and the 2 to 5-year-old flu, you could draw the same picture in Scotland, England, Ireland, any health board, exactly the same. The variation persists wherever you go. Exactly the same picture.
Yeah, I'm thinking more for programme managers that are looking to implement this in each board area might have a different variation in that. So I'm wondering whether some health boards might have a higher uptake rate, so it's a harder sell, whereas maybe they're lower uptake, so it's an easier sell for them in other boards.
Again, looking at the data nationally by health board, as I say, there are some differences, but they are not huge. Certainly, if you look at the childhood program and the school program, there are some bigger differences than the GP program. But if you look at the GP program themselves, particularly under 65 at risk and 2 to 5-year-old flu, again, I don't think there is huge variation between the health board uptake. David, can you think of anything? I don't think there is huge changes between the boards.
The same pattern about the range and uptake, I think, exists in almost all the boards.
That's what my understanding
there's
is.
some absolute differences in terms of the average uptake, but there's still...
Maybe 2 or 3%, but not a huge, really.
Yeah, I think that spectrum still exists.
Yeah. Any other comment, queries? Well, if not, as I say, we'll plenty of time at the end of the day, end of the session as well. We are running 15 minutes late, so if you could be back for 12 o'clock for your coffee, and then you can just put only 2 presentations, then you can go for lunch. I'm not sure whether Joy and Kerry will be stay for the rest of the day. If not, can you all thank them again for their contribution? Thank you. So if you could be back promptly for 12 o'clock, please. a start, please, so that you're not too much delayed for your lunch. So if you could just get your seat again, take your seat. What we'll do, we'll push back lunch to 1 o'clock by 15 minutes, and we'll restart after lunch at 1:45 to make up for the 15 minutes that we lost this morning. So thanks again for all coming back promptly after your coffee break. Now, this session before lunch, we got two speakers. These are the couple of the requests that came from the communication and engagement subgroup, or to the subgroup of the BTP steering group, and that's the two pieces of work done by colleagues. So they're going to present. Initially is Rachel Bishop from Scott Porter, looking at the findings from the research, followed by Emma. So what we'll do again, we'll take some question after both presentation. So over to you, Rachel.
Well, good morning, everyone. It's lovely to be here. I'm going to take you through the results from the research that was done, which looks at the public's views on vaccination service delivery. So we're looking at it from their eyes this time. The rationale behind this, so the research was commissioned by the Stakeholder Communications and Engagement Group, and it really was to give a snapshot of patient perspectives. And to have a think about what would be an effective vaccination process that supported uptake, that made people think, yes, I'll go along and I'll get that done. It was an idea to engage directly with the public. We looked at those who had their flu, pneumococcal and shingles vaccinations, with a view to giving information and providing some findings that meant that the business change managers could look and see what might help them in the development for the future. In terms of just a wee bit of context, we did the field work during flu season 18-19, so last October, November. And there are, of course, as you know, out there views on sort of vaccine hesitancy, should I, shouldn't I, and some growth in the anti-vaccine movement. In terms of what we did, we covered 18 extended 2-hour group sessions. So these are qualitative sessions rather than quantitative tick box questionnaire kinds of things. This really was a discussion. We had about 125 respondents in all, and split the groups across two main audiences. So 9 were done with those who were in the at-risk category for flu vaccinations, so they were aged 18 to 64, most of them in the less affluent SIMD areas of 1 and 2. We also did 9 groups with older patients, 65 to 75, again the majority in SIMD 1 and 2 areas. And they'd all been vaccinated for at least one of the 3 vaccines in the last 12 months. We didn't want to specify that they had to have had all 3 by the time they got to 75. And what that enabled us to do was to see why people picked one over the other, or had all 3, or just had the one that they wanted. We did this across a mix of urban and rural locations in various health boards. And it gave us a really good mix of people. Now, obviously, with a qualitative survey, it's not everywhere and the whole of Scotland. But I think from what we can say, we got a really good mix of different kinds of areas, different kinds of GP practices to give us a good look at what people thought. So, as I said, the focus was on the adult vaccinations, the 3 of them, and we talked to people a little bit about their views of vaccines to start off with, why they do and they don't get vaccinated. And then we focused in definitively on the process as it is now, how it is for these people to go and get their vaccinations, and then looked at what might be good for the future. In terms of vaccination, I think the first thing that we can say is everybody kind of said, well, vaccines are good for us. That was simple. That was, you know, an easy one to get from them. But on talking, I think there was a bit of a sense that the extent of the need for protection has kind of been forgotten a little bit. So flu vaccination has definitively the highest awareness, but for some it has less importance. They don't see much real flu. They couldn't say that they knew somebody who'd been in hospital or who'd had a really bad bout. So for a few of them it was like, well, it doesn't feel like it's personal to me. I can't think to myself, this is a disease that I need to worry about. It feels a little distant from them. They also sort of said that they felt there wasn't very much drive from the NHS to encourage people. Now, I know what you'll tell me is there's all sorts out there, but coming across, it didn't feel like the conversation from the NHS was, this is a good thing and we should all be doing it. That's where they were at. So vaccines are definitely important, but I think there are some out there who are thinking, do you know what, maybe this year I can risk it. I won't have it done, especially for flu. You know, that yearly thought, do I or don't I? In terms of the current process, now, across all of the groups, and I have to say as well, within the groups, so this is not like I could say in Aberdeen they did this, or in Edinburgh they did that. This is within some of the groups. There were so many different approaches as to how these vaccines were delivered, from the invitations through to the aftercare. And that was the first thing that hit me and my fellow colleagues doing it, and also I think within the groups, that thought of, your GP does that, mine does this. And we had a lot of those conversations. Each GP surgery seemed, to our respondents, to be doing it their own way. So there seemed to be little consistency across the board in terms of whether that was for invitations or whether that was for how it was done and what happened afterwards. In terms of the main issues, what they come up with is, do you know what, I don't think I'm getting the right knowledge about vaccinations. Getting all sorts of the wrong knowledge from all sorts of different other sources, from the media, from stories, from word of mouth, but how much am I getting that is right and tells me the right things? Invites are very hit and miss. I'll come on to that in a little bit more, but if it's hit and miss, do you really want me to do this or do you not want me to do this? That's what comes across. And access to appointments generally, trying to fit either ringing in and getting appointments, getting 2 appointments, it just doesn't work with so many people for so many lives. So the current process does hinder access to vaccinations. In terms of these issues then, let's think about them in a little bit more detail. Inconsistent or a lack of information. So they felt that coming from the NHS, there wasn't sufficient information offered or promoted. They weren't seeing leaflets coming out to them, unlike, for example, for screening, where every time you get a screening invite, there's a leaflet in there. You don't get it the same when you're looking at vaccinations. The wrong information just leads to worries, fears, misunderstandings. You know, what's in it? What about side effects? You know, in lots of conversations about what is this thing with all the different strains, and every year it's different, and some work and some don't, and the news says, well, it didn't work at all last year, so what's the point? All of that kind of information. And that kind of leads to them saying, well, do I take this seriously? And if I'm not sure if I do I bother going and having it done? The invitations, many of the initial invitations were a verbal, you should have this, which is fine in its way, but there are very few formal invitations being sent out. Some surgeries are doing it, but lots aren't. And there's no information with them. As I say, the leaflets don't go out. Pneumococcal and shingles, so often the mentions were that it was basically shoehorned into another appointment. Very often the flu. So if they'd gone in to get the flu injections, it was give me the other arm and I'll do that one while I'm here. Did you know you can have this? And so whilst people are willing to take a healthcare professional's recommendation, they're not exactly doing it on informed consent. In terms of making appointments, it can be very challenging, either to contact surgeries at a time that they can get through or to actually get in to an appointment time that suits. And there was another mention that if vaccines aren't in stock, you know, some people were calling every week for 4 weeks until someone said, yep, we've got some, now you can make an appointment. And then don't send me a reminder if you've not got anything there. Send me the reminder in 4 weeks when it comes in. It just kind of annoys. So lots of these challenges push people away from going. And if you've got a really busy life, you know, if you're on the train at 7:30 in the morning, you can't call at 8:30 to try and make an appointment maybe for that day that you don't even know whether you'll get and takes 2 hours to get through to make. It's those kind of things that then people go, what's the point? I'll risk it. I'll chance it. I'll try again next year. In terms of change, the big things that come out are, can we redesign an appointment process that supports uptake. This is what they're saying. Can we have a more efficient patient-centred service, please? And can we have something that offers more personalised call and recall systems, user-friendly appointment services? If we look into the future, this is what we want. So in terms of the recommendations for the future, I'm just going to run through, so this is from all of their thoughts, what they're saying they would kind of like. So in terms of comms, we need hard copy, but we need to be getting really good at electronic formats as well. And we need to think to the future for electronic formats. Apps, or at least an online portal, so many of them saying this enables you to do all sorts of things, everything from signposts to other information, notifications, a source for clinic sites. The use of online self-booking appointments. They're like, I could avoid the phone and if you just give me a system I can click on, I'll just put myself in an appointment slot. Don't need to call you at all. They're also saying in terms of especially invitations, we need a tailored choice to each patient. What's the format that best works for them? And that comes across again and again. And we see it in lots of other things in life where services, companies, all sorts say, how do you want to be contacted? And we give them that, we're given that choice. And they're saying, come on, let's get that choice going. In terms of general communications, so overall comms, they want messages that are really going to tell us why vaccination is important, so it appears relevant to them. We need to bring back this reason for doing it. And that it's worth doing for that individual. I think lots of them, it's kind of too easy to push it to somebody else. It's not quite for me. Visible, memorable things that work and stay in the mind. In terms of the programme information, it was really interesting here. They said, let's go back to basics here. I want to know what the vaccine is, what it actually does, why it's important for more than, and in their words, just old people and the vulnerable or ill people who'll end up in hospital anyway. We showed them the ad at one point and for last year, and they kind of said, well, that person was clearly ill. It still didn't relate to them. They want to know as well what it's achieved. They were like, if we don't know what this whole programme of vaccination is doing, then how can you tell whether it's worth it or not? Are less people going to hospital? Are less people getting flu? How are the figures over the years? Is the reason we've all kind of not worrying about it so much now is because it's been so successful that we've got to that point we don't need to? Why and what's happened? Which strains work? Which ones don't? Reminders that just because last year maybe wasn't quite so good, that doesn't mean next year won't be. Be factual and make it about life. And I think the interesting thing here was that they were sort of saying this is not just worst case scenario they want to see. What is actually important is if you say, do you know what, flu could lay you out for 2 weeks, and can you afford to be off work for 2 weeks? Can you get the childcare covered for 2 weeks? Can you afford to have that in the middle of winter with everything else that's going on and in your life? Do you, what happens if, rather than almost the hospital situation? They want as well for the NHS to be proactive as, and I put it here, the voice of authority. Be in charge, be the experts, be the people that say we know best and this is why, and we have the information to back it up. Make it the done thing to get vaccinated. In terms of first invitations, they're thinking that, and as I said, this needs to be formal. This needs to be a personal letter that says you need to have this. And it needs to be why you need to have this. I can think of one lady who said, she said, I know why I get the flu jab and I can have it. It's because I've got a problem with my liver, but I don't know why I need to get it. And I thought that's exactly the difference. They've just said, you've got a liver problem, you now need a flu jab. But she can't connect the dots as to why. And she said, I don't know. She said, I do because I'm good, but I don't know why I do. It's thinking, why that person needs it. And I suppose that's when they also say, can you focus on that vaccines? Don't tell me about other ones at that point in time. The invite is about this and this alone. A few people suggested as well referring to flu as influenza. Let's get back to the disease that it is and the one that actually makes it sound like it's a bit more serious, rather than, being man flu or something else that we might not take quite so seriously. if it's, the additional information is interesting. They don't necessarily want pages and pages and pages to read, everybody, but those who do want to be able to get hold of it. So we need some sourceable information, and format choice comes in there. If you want leaflets, you get leaflets. If you want a link to somewhere online, go that way. The information itself needs to be quick and simple at getting across what it needs to get across. And it's interesting, even while they say a letter from the doctor is going to make me stop, there are some of them that still want that in an email. So even though the formal letter for some is still there, just send it to me electronically. Reminders, especially, so this is more for flu. This can be really quick, and a quick, it's flu jab time is fine for a lot of them. But they're saying, just text me that. Some are already getting texts from people. They're saying, this is when these things are useful. Text me that that's there. Add a web link so I can go on and ideally just book it in while I'm there. Then I've done it all in that moment, you've done it. Put web links in that signpost me to information. Again, a letter might still be needed for some. This goes back to that original tailor that information for the patient. Making the appointment. Unsurprisingly, given the conversation that we had about trying to get hold of GP surgeries at times, please make it simple and at our convenience. Some said, okay, if it's got to be there, give us a dedicated phone line so we're not battling everybody else who's trying to get through to a surgery. Develop electronic booking systems. Use drop-in sessions. I don't really mind that, but they've got to be efficient. There were some hysterical stories of drop-in sessions where it didn't really work. And the queues were around the door, and they spent hours trying to wait for flu jabs and things like that. Efficient, good, all fantastic. Opening hours, links in, so it should feel possible to pop in easily for each individual to get this done. So we need to think different hours, early mornings, late nights, Saturdays, and what links into this is then the location. So if you can extend the locations that people can go to, it opens up the times that they can go to get it done. So, for example, if you have to go to your local surgery, but you work an hour away on a commute, you need to be able to go to somewhere where's at work, somewhere near to work in your lunch hour, and you get it done. Not to have to think, I'm on the train from 7:30 in the morning and I get back at 7 at night, how am I ever going to get to my GP surgery? So in terms of locations, what they said was this has to be local and near to me, to wherever I am, I tell you, as well at that point. It has to be easy to get to access, to park. It has to be private, clean, safe, and it has to be able to link into NHS records. So at this point, they're kind of thinking, if I can pop in anywhere, I still need to know that if I've been seen, it all links back and it goes on my records. So GP surgery buildings are a logical choice because that's where you can go. They mention pharmacies, but then they go, usually they're a bit small. Could they cope? Community buildings, town halls, community centres, leisure centres, hotels, function rooms. Not if it seems like they're going to the pub, but otherwise fine with that one. And then they talk about mobile units. Well, blood transfusion services use them. The breast screening service uses them. Why can't you have flu mobile units that go around? Basically, they're like, do you know what? Cost it all out, pick the most effective ones, and then for each area, we'll know this is the place you go to have your vaccines done, to have your vaccinations. And it becomes the place to go, and within any local community, it's known. So who should run this service? Won't be pleased to see it does say the NHS. Definitely the NHS, that was easy. With trained and professional staff, that goes without saying. And what they think would be really good if you have a service that is all about vaccinations is they're experts, in giving injections, and everyone has a story of people who can't do that very well, and also experts in vaccines. So the questions they might have about, I felt like this after last year's flu jab. Is that normal? Was that whatever? Is it going to be as bad? These are people who really know vaccines, and therefore they can ask them kind of anything. Only very few wanted to know the person, kind of a bit of comfort levels, some of them because they were very good at giving jabs. But they kind of said, you know, again, if you've got always the place to go for vaccinations, you might see the same team every year. So using the same teams in a place also gives that bit of comfort. When we talked about a local or a central service, they said central seems best. Now, I have to add the caveat here that central, they don't kind of think in health boards. So when they're thinking, they're just thinking for want of a better phrase, NHS Scotland. So it's just the NHS that does this. So they're thinking broadly. This seems to be more efficient, time, expertise and costs. And they kind of say, you know, if you can get this really efficient and good service going, that's going to prove its worth. And if it's Scotland's vaccination service, then again, it's a little bit of this kind of, let's have a buy-in to this. You know, this is there and it's for all of us and we should all take notice of it. On the day, please can it be quick and efficient? It generally is, I have to say. Sometimes really efficient. So there were some of them who said literally the sign outside says, take your coat off, roll up your sleeve, get your arm ready. They go through the door, stand there, they don't even sit down, get the jab, and they're out the other door on the other side, and the next one's coming in behind them. So there is a slight worry at that point that actually not so quick and efficient that you couldn't stop and ask a question if you wanted to. And I do think that person kind of said, it was literally like I could have stood on a conveyor belt and they'd have just like got me as I went past. In terms of aftercare, there's not really much that is talked about just at the minute, and it kind of depends on the person giving the injection. What they were saying is if there's not much time and you want to be efficient, then consider a wee takeaway note, a leaflet, a little credit-sized keep me, something that says thank you, it was important you did this, that reminder, listing any side effects, anything that they might feel. And I suppose I should say as well, they all say they get side effects, and they get a bit annoyed when people say to them, you don't get side effects from the flu jab, because there is too many stories of people who feel that they do. So it's kind of how you word that and how the understanding gets through, but it is quite annoying to people who feel that they've had a really bad time afterwards and it's dismissed. So we want some signposts there, what to do, a signpost to more information, and again this kind of reminder that, you know, you might get some flu-like symptoms this year or some coldy-like symptoms, but, you know, next year's vaccine will be different and it might feel different as well. In terms of just last couple of things, should this be for all three? Yes, it should be for all three adult vaccines. The process should apply for all of them, and they didn't see there was any issues, even though flu is the big one, building in pneumococcal and shingles as well. And interestingly, some of them said, why don't you have, if it's central, like a twice-a-year vaccine push? So you keep your kind of flu one in the autumn, you add a one in May, and everyone that kind of turns 65 or 70 for the pneumococcal and shingles gets a call in to come in at that time. And so you get efficient at getting everybody in. The other thing that they said, and just one last point, is ID systems. Now, if you're going to move out of just going to your GP, they all said you've got to make sure that you've got an ID. So finding something that they can use. So is it, you know, their NHS numbers? Is it barcodes like in the bow screen? And they went, well, that's got a wee barcode thing. Can we not have something like that? And some of them said, you know, can we have a little wee book, a passport, the card that's got your number on, and then wherever you go. So one of the girls in Edinburgh was saying, she says, I work in the middle of Edinburgh. If you gave me an app that showed me a map with all the local clinics on, and I could just click on a clinic and I could find a time at lunchtime and I could go and I could book it in and I'd go at lunchtime and I'd give them a wee number and I'd know it was done and it would go back to my doctor, happy days. And that would actually get her to do it, whereas at the minute it's a bit hit and miss because she can't get to her GP surgery. So all in all, I think what they were saying is, can we be, it's being efficient, it's looking at it from a bit of a patient perspective as well, but I think more than anything it's giving it that importance back, giving it a bit of a reason why it's important that everybody should do this. And so adding that to making it easy to go will encourage uptake. That's everything from me.
Right, just pass it on to Emma, right, and then she will probably have 5 minutes for questions before lunch.
Good afternoon. I'm going to follow up on Dr. Tomlinson's reference to health inequalities and focus on populations who do experience significant inequalities in terms of vaccination. So Health Scotland provided support to the vaccination transformation programme in its first year by undertaking a rapid evidence review. On interventions to improve engagement with underserved populations in immunisation programmes. And I'm here today to share the findings of that review. So vaccination programmes have been shown to reduce health inequalities worldwide, but there are still populations that the health services find difficult to engage with, and as a result, underserved populations experience significant health inequalities in terms of vaccination. Barriers are many, varied and complex, and poor access to healthcare services, marginalisation, poor health literacy, culturally derived attitudes, fear and distrust, language barriers, and in some countries cost are all barriers to this group. Underserved populations are therefore under-vaccinated, and this puts them at increased risk of morbidity and mortality from vaccine-preventable diseases. So standard approaches to vaccination delivery may have limited effectiveness for these populations, and therefore the vaccination transformation program is an opportunity to find new ways to design and deliver immunisation programs, taking into consideration the needs of these underserved populations. So we sought to identify effective interventions to improve engagement with immunisation programs in 4 underserved populations. So we defined as an underserved population as a group of individuals from any ethnic background who, due to social circumstance, disability, language, culture, or lifestyle, find it difficult to access health or health services. They can comprise a number of different populations, such as migrants and refugees, people who are socially disadvantaged, nomadic groups, people who are elderly, homeless individuals, or housebound individuals. Due to time constraint, it wasn't possible to cover all underserved populations, so we selected 4 underserved populations, and these are people from deprived areas, people whose first language is not English, people with learning disabilities, gypsy traveller communities. And we worked with the review advisory group and local business change managers for the VTP to select these groups, and we used a prioritisation process. So we used systematic methods to identify, critically appraise and synthesize peer-reviewed literature. A literature search of 7 databases identified 1,149 English language studies, and this was the dates between January 2013 to August 2018. And we selected studies if they were conducted in high-income countries. They assessed an intervention that aimed to improve vaccination uptake or to change an intention to vaccinate. We included 17 studies, and then we found 3 more through references of other relevant studies. So a total of 20 were included. It was fair to say that the evidence base was thin. 20 studies is not a large number, but we didn't include grey literature, and we was limited to English language studies only. The evidence landscape was mixed in terms of study design, so we identified a number of systematic reviews which brings together primary studies. So for people from deprived areas, we found a systematic review which included 41 studies. So there was a range of interventions that they evaluated. And this contrasts with 2 systematic reviews. We identified people with learning disabilities where they evaluated only an intervention, just a single intervention. Populations were heterogeneous. Studies for people from deprived areas and people whose first language is not English were primarily conducted in the United States. UK studies were represented amongst people with learning disabilities and gypsy and traveller communities. Interventions covered a range of immunisation programs, and the quality of the studies varied immensely as well. So for the following, over the next couple of slides, we'll look at the individual populations in more detail. So the evidence base was most developed for people from deprived areas, where a range of approaches were evaluated in 8 studies. And as mentioned before, one of these was a systematic review of 41 studies. The studies largely came from the United States and varied in quality and study design. Deprived study populations tend to be heterogeneous in terms of ethnic and cultural diversity, and these were predominantly urban. This maybe calls into question whether the interventions tailored to these populations have transferability to the UK. There were multi-component interventions featured quite heavily amongst all age groups, and there was great heterogeneity in their component parts. And these, because of the interventions were tailored to support the individual populations. We identified 5 studies for people, for children and young people, 2 studies for postpartum and pregnancy periods, and 1 in adult population. So the evidence for children and young people predominantly came from a large systematic review, and this updates a 2009 systematic review which underpins the NICE public health guidance on reducing inequalities on immunization in under 19-year-olds. And this study looked at complex multi-component interventions, reminder and recall systems, outreach programs, and computer-based interventions. And it suggested, it suggested that locally designed multi-component interventions provide the best evidence for vaccination uptake in urban, ethnically diverse children and young people. Multi-component interventions typically included 2 or more interacting components, and these could comprise identification, promotional materials, education, patient reminder recall systems, outreach such as home visits, training of healthcare workers, prompts for healthcare workers, additional clinics, non-prescribing healthcare professionals, and/or community involvement. The review also concluded that interventions that included a home visit were mostly showed some evidence of effectiveness. Escalating the intensity of an intervention was mostly effective and could be a cost-effective approach of including home visiting into a program. Outreach interventions were not effective, alone were not effective. There was mixed evidence for social marketing, but this showed promise among adolescents. There was limited evidence for text messaging, reminders, and centralized reminder and recall systems tended to work better than practice-based ones. We also identified some evidence for systematic review of school-based health centers and increasing immunization rates in the United States, but this is limited application to the UK as school-based delivery of childhood and adolescent immunization program already occurs. A number of interventions targeted parents to increase awareness of vaccination in children and young people or influence behavioral intent or status. The first of these studies featured a social marketing campaign, and the second involved a post-campaign with alongside an in-clinic health information technology system. However, both these studies only showed modest effects in terms of vaccination behavior. We also identified a randomized study of a reminder intervention which flagged unvaccinated children and adolescents to healthcare providers. The intervention modestly increased influenza immunization amongst non-up-to-date children, and this was particularly during late winter months when fewer vaccinations are usually given. In two studies, the prenatal and postnatal periods were used as opportunities to improve vaccination uptake amongst deprived mothers and their infants. The first modeled a pre- and postnatal home visiting program by certain nurses, and the second evaluated a multi-component intervention that tackled barriers such as cost, on-site access, convenience, and language to improve the uptake and completion of HPV amongst postpartum mothers who were unvaccinated or partially vaccinated. And these had reasonable success, varied success. Evidence for interventions for adult populations was limited to one pharmacist-driven research program, and it was a retrospective study. It featured a multi-component intervention again, and it involved identification of individuals who were eligible for free vaccination, additional education, and multiple vaccinations in one pharmacy visit. However, it was difficult to assess the impact of this intervention because of the poor data quality. Moving on to people whose first language is not English, evidence for interventions to improve vaccination uptake came from 6 studies conducted in the US and Canada, and evidence was rated as low or moderate quality, and they focused on HPV and hepatitis B vaccination. Linguistically appropriate information such as translated resources or bilingual facilitation featured in all 6 studies. 3 studies evaluated educational interventions, and these were a photographic short story known as a photonovella, a pictorial brochure, or a bilingual workshop. And these were used to increase participant knowledge of a disease area and hopefully to change behavior in terms of their intention to vaccinate. In these three studies, subjects acted as their own controls, and there wasn't any randomization, so it wasn't possible to attribute results solely to the intervention. It's also important to note that although some improvement was noted in the intentions to vaccinate, these aren't always very reliable. They don't always translate into actual vaccinations, and so therefore may not result in greater vaccination uptake. Multi-component interventions in community settings were evaluated in 3 studies, 2 non-randomized studies and 1 large-scale randomized control trial evaluated culturally and linguistically tailored multi-component interventions to increase HPV or Hep B vaccination. They all reported high rates on completion of the 3 doses in the intervention compared with control groups. And they suggest that education as well as additional support, such as reminders, outreach or patient navigation, may improve the completion rates of programs which involve multiple injections. Of these multiple component studies, one took place in a Mexican consulate in the US, the other one involved 32 church-based community organizations. So therefore, non-clinical trusted community settings are potential locations to implement interventions. For people with learning disabilities, 3 studies of moderate to high quality evaluated variations of a screening tool known as a health check. And this helps to identify, prevent, and manage health problems in people with learning disabilities. Immunization status was checked as part of this screening tool. 2 well-conducted systematic reviews both reported 2 randomized controlled trials which evaluated effectiveness of this health check. And one of these also, systematic reviews also identified a Scottish matched cohort study. Together, these 3 studies, they did a pooled analysis of the primary studies of 795 individuals, and these showed increases in hepatitis B, diphtheria, tetanus, and influenza immunization in the health check group. And there was relatively low bias in this in the methodology of these studies, so it's likely that these results can be reliable, though given small numbers, but potentially generalizable to a wider learning disability population. However, a further randomized control trial did show that the health checks conducted health checks showed some positive results in terms of identifying immunization, but again, these needs are not always acted on, and they found that there was relatively poor follow-up immunization in terms of non-influenza immunizations amongst the randomized control and intervention groups. However, this study also noted there was cost savings compared with standard care. So these studies provide some evidence to support the use of health checks in people with learning disabilities. Health checks aren't conducted in Scotland. The Health Needs Assessment Update report published in 2019 does call for development of a national health screening program for people with learning disabilities. 3 studies for Gypsy and traveller communities reported strategies to increase engagement of this community with immunisation programs. Outreach programs such as mobile clinics, professional and lay outreach, and the use of dedicated services to improve immunisation rates were reported in 2 well-conducted reviews. Although the methodology of the secondary evidence was very good, it doesn't always reflect the quality of the individual studies, and the effectiveness of the interventions was either not reported or was not robustly evaluated. The most convincing evidence for this on interventions to engage this group in immunisation comes from a 3-phase qualitative study, which is the Uniting study. Now, this is a large study and engaged family members from 6 different travelling communities from 4 UK cities. They also engaged healthcare workers, and between they used an approach where they came up with 12 interventions to increase vaccination uptake, and 5 were jointly agreed on. These 5 were cultural competence training for health professionals, identification of travellers from health records, provision of a name, front and person in GP practices, flexible and diverse systems for booking appointments, and protected funding for health visitors. These interventions may have the potential for greater success due to the stakeholder engagement that they've created. The intervention is also potentially complementary, but they need to be formally evaluated to see if they're effective. So the evidence-based is perhaps most developed for deprived populations, and definitely to a lesser extent people with English as a second language. This contrasts with people with learning disabilities, for whom one type of intervention that we found has been evaluated, and for Gypsy and traveller communities for whom effective interventions have yet to be evaluated. However, the findings of this review do suggest a range of approaches have been adopted to improve uptake amongst underserved populations, and that the range of approaches that have been adopted are effective ones, may be complex and involve multiple components, and they suit the local needs of the population. So we can't make recommendations from a weak evidence base. What we can say is that when planning the immunisation service, engagement with the underserved population is really, really important. It's worthwhile considering approaches that influence people's behaviour by offering patient navigation, outreach programs, reminder services for patients and healthcare providers, and perhaps social media campaigns. It's important to increase awareness and knowledge of immunisation through tailored education and information that involves translation. Perhaps using non-clinical or trusted community settings might be important. We noted that many interventions involved all of these components or some of these components, but it's not possible to identify which component is the most effective. Indeed, given the popularity of multi-component interventions, it highlights and it reflects the need to overcome multiple barriers that exist to these underserved population, which may exist at patient, provider, or organizational level. Identifying facilitators of immunization are important, and they will enhance vaccination. And the community-based participatory research approach featured in a small number of studies, and given the NHS board vaccination services will be designed and delivered locally under VTP, this approach might be worthwhile considering in developing community-specific interventions. So this is a developing evidence base. The challenge is to generate more evidence that has a Scottish focus. The VTP is an opportunity to add to this and to evaluate interventions you're piloting as part of your service redesign, and sharing what works and what does not. Your experiences are important, and I guess we'd like to hear about what's working well in your areas in this community. So the links to the report, there's an executive summary and the main report are on this web link. I just want to acknowledge people who participated in this report, and many thanks.
Thank you very much. I should also say is that with the permission of all the speakers, all the slides that have been used today will be posted into the NHS Health Scotland website, and we'll send you the link. Okay, so you'll have access to all the slides with the permission of all the speakers. Obviously, we haven't got that yet. Okay, so up to 15 minutes max. But if you want to finish early, you can go to lunch early. But have you got any question for our two speakers, Emma and Rachel? Sorry, Joy. Yeah.
It's just a reflection, really, but I'd be interested in your thoughts about providing people with fixed appointment slots. And I'm thinking back to the Keep Well programme, which ran a number of years ago in Scotland, and we looked at comparable uptake rates of appointments which were open and people opted in, and fixed ones. And the fixed ones worked better in terms of uptake. So I'm interested about, the providing people with options, but actually sometimes the options don't result in maybe what you want them to.
Yeah. I would agree entirely. What I would say to that is, and I'm thinking back to a piece of work that I did for AAA screening. And for that one, the guys who were sent out their invites just said, do you know what, just give me a date and a time and I'll turn up. And they do. I think the big thing with vaccination is the spread of the people that you've got. So I think there is scope for certain groups who definitely, if you give them, because they do what they're told, so they'll go and they'll do. And I can see that would definitely work. I think for others, that it would annoy some, because they would just be like, now I've got to ring and cancel the wretched thing, So you've immediately put something on the to-do list because they can't get there at that point. So I suppose, and when I was saying go through it, it's thinking about how you can get each different group in. But yeah, I definitely think there's scope for some to do that, but certainly the at-risk group, the younger ones, that sounds terrible, but you know, you've got to pick the right people, and I think a lot of them are like, just give me more scope to get out there and go somewhere else.
Yeah, I think the flexibility of different approaches is the key thing. Need to be flexible because everybody is different. One size don't fit all, and you just need to have to make sure that we get this flexibility. Any other? Well, as I say, you'll hear this afternoon from all the 5 health boards in the west of Scotland. They will be presenting, first of all, where they are, how they're going about in implementing, and some of the key challenges they've been facing up to now in delivering some of those programs. So what we'll do, if without a further ado, we'll probably break for lunch. I said we'll restart at 1:45, but it's buffet lunch, isn't it? We managed to regain some time. So can I suggest that we try to be back for 22:01, so you can get you home early as well. 22:01, and there may be some more questions at the end of the session. 22:02. So I'm behind my time. Maybe 22:02. So don't gulp your food. Enjoy your food, and then we'll see you here. Okay, thank you. Sorry, can I just put